maybe for pain treatment and for cancer and for neuro interventions and also for musculoskeletal and spinal interventions. For the chapter of musculoskeletal and spinal and pain intervention radiology, we are using the same tools in general intervention radiology like embolization and ablation. And the ablation may be directed to the tumor itself or may be directed to the nerve. The new about this is that we are targeting the nerve by either local injection of what's called the block and also for ablation, what's called the neurolysis. And the neurolysis by ablation may be by heat. And if this by heat may be by 70 degree or 80 degree or 90 degrees Celsius, and also maybe by a negative heat, which is called cold or cryoablation. So when we are describing the pathology, the same slide in all presentations, this is the panorama for all what we do. We treat the pathologies of the spinal pain or musculoskeletal pain or cancer pain and also for cranial pain. For the spinal pain, we treat sciatica, discogenic pain, facetogenic pain, muscles of the back spasm, and the paravertebral muscle masses and filled back syndrome. And also for musculoskeletal pain, we are treating benign conditions like osteodysteoma and malignant lesions by palliative ablation for malignant musculoskeletal metastatic lesion or embolization. And also for cancer pain, we are treating cancer pain by if in craniofacial or upper abdominal or lower abdominal, and we are treating also cranial pain by treating the headache by the cervical nerves and the greater occipital nerve ablation or block or cranial neuralgia, and also treating the trigeminal neuralgia by doing a trigeminal nerve block. We are killing the cancer by alcohol, radiofrequency, microwave, ultrasound, laser, and cold, and also ischemia. This is what we can kill the cancer. Also, we can kill the nerve by the same maneuvers, and also we can kill the cancer pain by the same way in every place. So, what is the cryoneurolysis? It is referred to the use of extreme cold, -70 Celsius, to reversibly ablate. And so we are talking about cryoablation. It's reversible, not irreversible, because the reversibility is important in some nerves and the irreversibility is important in other nerves. So the difference between cryoneurolysis and the thermal ablations, that cryoneurolysis is doing reversible nerve damage. And also it causes Valerian or Valerian degeneration without damaging the surrounding tissues, and it's a temporary long-term relief, maybe from 1 to 5 years. After that, the mechanism of action by it's directed to the nerve by the needle and creating an ice ball. You can see the ice ball here. This is the ice ball by shadowing in ultrasound, and we better to do cryoneurolysis so under guidance of ultrasound. And this is the ice ball. We can see the ice ball here. This is the ice ball in the air here, and this ice ball here it will take 1 minute or 2 minutes of cryo power, then 1 minute of negative power, then 2 other minutes. It may be to cycle up to 7 or 8 or 9 cycles, and after that you can see disappear. The historical background from Hippocrates using the ice for pain. This is the first use of pain for ice for pain control, so it can freeze the nerve in any place in the body. The imaging guidance, we can use ultrasound like this, and also we can use fluoroscopy for cervical facet cryoneurolysis like this, and also we can use CT guidance. The negative for the CT guidance, that the cryoprobe is heavy and it need to be supported if we are using CT, or we can use ultrasound or fluoroscopy, and after that we can use CT or cone beam CT after that to properly direct it to the nerve itself. The clinical application for cryoneurolysis by chronic pain syndrome, post-surgical neuralgia, we can do post-surgical neuralgia treatment and also by doing ablation to some nerves, some peripheral nerve. Cryoneurolysis is the superior, and it is the main treatment for peripheral nerve, and also for peripheral neuropathy, and for post-traumatic nerve pain. The musculoskeletal, it is the first for treatment of knee osteoarthritis because it is superior than radiofrequency ablation, and for shoulder joint pain because the suprascapular nerve we shouldn't ablate the suprascapular nerve because it has a motor supply. But if we are doing suprascapular nerve cryoneurolysis, and after 6 months we can there will be a regeneration for the nerve, and for the 6 months we are doing habilitation for the patient undergoing shoulder arthroplasty, it will be better. It will be the best choice for this patient. For the spinal pain, it is superior for lumbar and cervical facet, and for sacroiliac joint pain. For preoperative application, the main application also for the thoracotomy. Thoracotomy, we are doing the surgeon doing the thoracotomy, and there will be fractures in the spine, and will be in the ribs, and there will be pain from healing and also after trauma. So what we will doing, if we are doing radiofrequency for the intercostal nerve, the radiofrequency power will result in pleuritis or pleurisy and will exaggerate the pain. The heat can induce inflammation of the pleura, of the underlying pleura. So the cold has a soothing effect for the pleura. The needles for the cryo ablation are blunt in some cases, and we are doing application of these blunt needles in the intercostal space without fear from injury of the pleura or the lung. And also for mastectomy pain, shoulder arthroplasty, and total knee arthroplasty. The advantage over other modalities is that the cryoneurolysis has a negative soothing effect, no pain during the application of this negative heat, but there will be severe pain if we are doing ablation at 80 or 90 degree for knee osteoarthritis or facet arthropathy. Effect of the nerve, the cryoneurolysis has a reversible degeneration, but the radiofrequency has irreversible degeneration. The post-procedure recovery, the patient has a spontaneous recovery and simultaneous recovery for cryoneurolysis, but the nerve may be irritated by radiofrequency, so the patient may take 1 to 2 weeks for recovery, and the action for radiofrequency will take up to 6 or 7 weeks. The pain recurrence for cryoneurolysis is gradual pain recurrence. The safety near vessels is higher safety for cryoneurolysis if we are near some vessels. Our experience in Asia, we are making our center, was the first center to introduce this machine. We did over 50 procedures performed in 5 months. Knee osteoarthritis, intercostal pain, post-surgical mastectomy pain, chronic inguinal neuralgia, pudendal neuralgia, facet arthropathy, sacroiliac pain, and also treatment of premature ejaculation as well. And the significant pain reduction was experienced in most of cases. So this is the machine. This is Metrium Cryoflex machine. In the market, there are 2 machines for cryoneurolysis and 3 machines for cryoablation for tumor and for nerve. The 2 machines are the machine for cryoneurolysis. This is from Poland, and this is another machine from Germany. And these are the custom to, you can see the negative pressure here, and you can see the timing here, and this is a foot switch for this. And this is 78, and we can see this for using nitrogen oxide or CO2. The same. This is the ice ball. You can see the ice ball here. This is the ice ball here on my hand. This is a case for knee osteoarthritis. You can see we can make ablation of knee nerves around the knee from 3 to 7 to 13 in many literatures. So the most common ablated nerves are the upper lateral genicular nerve, upper medial genicular nerve, and the lower medial genicular nerve, and we can ablate in this point and also at this point, and also we can ablate the suprapatellar nerve, maybe 5 nerves, and these 2 nerves here, nerve here, nerve here, and nerve here, so they are 5 nerves. In many cases, I'm doing now 7 nerve protocol by making more ablation here and more ablation here. But these 4 locations are seen well by ultrasound, so I prefer this 4 location in cryoneurolysis. And you can see the ice ball, and this is the shadowing for ice ball, and the landmark for us is the vessel, the genicular artery, and this is also the ice balls here, and the patient has a spontaneous recovery at the same time without any dose of corticosteroid, with only local lidocaine on the skin. This is a special catheter we use in some patients for sacroiliac. It seems like simplicity. You can see these are the nerves 1, 2, 3, 4, 5, 6, 7, 8, 9. Up to 9 nerves supply the sacroiliac. If there is severe pain for the sacroiliac, we are starting by sacroiliac injection. If the pain persists, we may do selected radiofrequency for this point, or may use simplistic catheter by making it around this and doing cryoablation or radiofrequency for all this area. After that, if there is resistance to the pain, we are doing percutaneous sacroiliac fixation, and we did it successful in some cases. For facet pain, for the lumbar facet pain, you can see this direct by fluoroscopy, but in many cases I'm using ultrasound as my guidance. First, and then locate and then confirm my location by fluoroscopy for facet pain. In this case also we are using it by in cervical pain to be facetogenic in origin. We can the cervical pain may be occipital neuralgia and maybe facet arthropathy or maybe brachialgia. We must differentiate between these types of cervical pain. And the patient has a neck pain, and we are doing C4 and C3 and C5 at this location for facetogenic pain from cervical facet. And also for myalgia parasitica, we are doing also lateral femoral cutaneous nerve of the thigh by cryoablation. The cryoablation is the superior treatment modality for myalgia parasitica. It is the superior modality, better than radiofrequency, because for the peripheral nerves, radiofrequency may cause irritation and increase the pain. Pudendal neuralgia also, this is the CT guidance, and this is fluoroscopy guidance of one of some of our cases by pudendal neuralgia treatment. Also, the treatment of pudendal neuralgia by cryoablation is the superior treatment modality than radiofrequency. And this is the location. You can see this is a heavy probe. For thoracotomy pain, this is a demonstration, this is a T, but I prefer ultrasound guidance with some sort of trocar to make ablation for the intercostal nerves by cryoablation, and also for premature ejaculation, as with the aim is to decrease sensitivity of the glans penis and to make it reversible, not irreversible. The surgeon doing neurotomy, so we are doing one side for about 1 centimeter below this tuberosity, this tuberosity, to make dorsal penile nerve ablation by cryoablation to decrease sensitivity and to regain the activity again. The complications are not major complications like local pain and temporal numbness, rare complications like neuroma, but the cryoablation also is the first treatment modality for mortoneuroma and for post-phantom limb syndrome and post-amputation pain. And the limitation, it needs precise imaging and also limited evidence in some cases, and we are knowing that also the research study about the comparison between radiofrequency and the cryoablation are not so much in literature. In the future perspective, also the integration of robotics and navigation system and expansion to oncological pain, because in some oncological pain it's difficult to do cryoablation like in celiac block, because it is a plexus, we couldn't ablate this by this. However, there are some papers speaking about this, and also potential AI-assisted targeting and prediction. And in conclusion, cryoneurolysis represents a great shift in imaging guiding pain interventions, sim and precise and well tolerated, and an evolving tool that should be in most intervention radiology centers. Thank you.
شكرا دكتور احمد على البرزنتيشن جميله. بس هو انا بتكلم على الافيلابيلتي بتاعت الماشين دي، هي موجوده في مصر في اكتر من مكان ولا الدنيا؟
هو لسه، هو انا معايا واحده والشركه معاها واحده بتأجرها، بس لسه يعني في الاول يعني، هي لسه
يعني
مترخصه جديده، بس هو في لسه بقى فاريانت بتاعت سيمنز لسه بيحاولوا يدخلوها مصر اللي هي الكبيره دي، بنحاول نجيبها عندنا بقى.
والكوست بالنسبه للمانوفرز الثانيه هتبقى قريبه ولا الدنيا
اعلى
بعيد؟
سنه، اعلى سنه شويه. يعني لسه، بس ممكن بعد كده تبقى اكتر، يعني تبقى كومون، يعني لما تيجي غالبا هتبقى قريبه من الراديو فريكونسي.
وهي البروب بيبقى سنجل يوز؟
في بروبز مالتي يوز ل 50 او 25 استعمال، وفي بروب سنجل يوز حسب بقى ايه التارجتنج والاريا، يعني بتاع السايكل يقول لك مثلا سنجل يوز، في بروز معينه عشان بتتاقلم في الاوتوكليف وبتبقى تخينه كده، يعني في بروبس كده يعني حسب بقى الديزاين بتاع الشركه، يعني في شركات عامله كده وفي شركات عامله كده.
طب وبالنسبه للبين، هي بتدي يعني بين الريف بيريود قد ايه؟
حلوه، لا ممكن هي المفروض تقعد مثلا 5 سنين.
5
يعني
سنين.
لو هي عملت البين ريليف بجد، اصل هي ميزتها ان مفيش اللي هو الفولس بين ريليف، يعني في الراديو فريكوانسي انا بحقن لوكال انستيزيا، من اللوكال انستيزيا بتدي او كورتيكوستيرويد بعديها عشان مفيش نيورايتس، ده بيدي ممكن يدي فولس ريليف، ممكن اصلا يكون تحسن من الكورتيكوستيرويد، يعني ممكن يكون اصلا لو ما عملش فريكوانسي، اما مفيش ايفيدنس كويس على كومباريزون ما بين البلوك والراديو فريكوانسي. بس ميزه الكرايو ان انا ما بحقنش بعديه حاجه، انا بدخل ابره واطلعها، اما العيان يقول انا حسيت بتحسن اكيد من الكرايو.
تمام. تمام.
أنا بس قبل ما نختم الجلسه، انا ليا سؤال للدكتور جمال، معلش. هو حضرتك طبعا الدكتور جمال نيازي، حضرتك بايونير في الراديو فريكونسي ابليشن والمايكروويف في الاوستيويد اوستيوما. الليجنز اللي بتبقى في السيرفايكال فيرتبري والدورزل، هل في ريسك من الهيت انجري للسباينال كورد، ولا بتبقى ولا في بريكوشنز معينه من خبره حضرتك ممكن ناخد بالنا منها؟
طيب هو الليجن بتاعت السيرفايكال سباين انا اي دونت دو ات عشان حفاظا على الكورونرز بتاعتي، بس عشان يعني بس عندنا اساتذتنا بيشتغلوها، واعتقد يعني الدكتور عمرو ناصف اعتقد اشتغل كذا حاله سيرفايكال سباين وعنده خبره بيها يعني. دورسال سباين اشتغلت دورسال سباين ولامبر وسيكرال. لازم النيورو بروتكتيف تولز. احنا من اسبوعين يمكن احمد كان عنده حاله دورسال سباين كنت معاه فيها برضو، جديد فيري ويل، جديد فيري ويل. النيورال بروتكشن، عمل نيورال بروتكشن كويس، وحط ثيرموكابل وحقن هواء وحقن ديكستروز، وعمل كل النيورال بروتكتيف ميكانيزمز. طبعا الليجنز اللي موجوده في حتت في السباين سيف، سباينس بروسس بيديكل حواليها كورتكس كويسه، ما بنبقاش خايفين وقلقانين. انما الليجنز اللي بقى فاتحه على النيورال ستراكشرز وي شود دو نيورال بروتكتيف ميكانيزمز. سيرفايكال سباين لو احمد عمل يمكن في السيرفايكال يقول لنا،
عمل سيرفايكال
برضه كويس، انصحك ما تعملش كويس.
شكرا دكتور جمال. any other questions؟ هو للاسف طبعا في بعض السبيكرز ما جوش، اعتذروا، فكده احنا وصلنا لنهايه الجلسه بتاعتنا. شكرا لحضراتكم.